Hi, I'm Christopher Jones. I try to keep up and read my journals. Our main journal often has some really important things in it. This is one of the most important papers I've seen come out in years. Dr. Rod Rohrich from my medical school alma mater in Dallas, Southwestern. Amazing researcher. He's published lots of papers. This one, he and his co-authors looked at 42,000 consecutive plastic cases. That's a tremendous, tremendous amount of cases. It was a retrospective review, which means they looked at the complication rate and the conditions of each patient, tried to look at what are common factors for success and what are common factors that made the chance of complications increased. There's no plastic surgeon that doesn't want to read this article here. After 42,000 cases, an overall complication rate of 0.74%, 0.75%, which sounds pretty good to me. But some of those complications, as rare as they are dangerous, especially venous thromboembolism, a blood clot forming in your legs going to your lungs. Other complications, major wound complications, hematomas, a buildup of blood under the tissues, hemorrhage. Some of those still are serious enough to at least need another operation. Those are all things that we want to avoid. The three biggest factors that seemed to increase the chance of major complications. Interestingly, age was not a big factor. So I get a lot of older patients who are scared because they think, oh, I'm too old for this surgery. We surgeons go by physiologic age rather than chronologic. I have 75-year-old healthy as a horse patients that I've operated on several times with good benefit. And I've run across 26-year-olds who are already in very poor states of health and abuse themselves with drugs, alcohol, other things, and I wouldn't want to operate on them. So physiologic age, how healthy you are, is more important than chronologic age, how old in years you are. So that one didn't surprise me that it wasn't a big factor. I have talked to my patients before about body mass index. It's a crude estimate of how much fat you got on you. Now, there are instruments we have here in the office, I have at home. They're available on Amazon for less than $100 that measure your body fat percentage by having you stand on two little metal plates with no socks on. And it calculates the electrical resistance of your body and therefore calculates how much fat versus water-soluble materials you have in you. And it'll give you a body fat percentage. That's a better way to determine your body health by looking at fat. But BMI relates your height to your weight. It's a pretty good, quick and dirty way of looking at things with a couple of exceptions. And it turns out in this article, body mass index was a big influencer in outcome. A body mass index of greater than 30 was associated with a higher incidence of venous thromboembolic events and other major complications. Until this article, my kind of cutoff was, I would explain to patients, between less than a BMI of 32, the outcome's generally pretty good. Between 32 and 36, that's my iffy zone where I can't look the patient in the eye and tell them it's going to be good because their body wall is too thick for me to be able to do what I know how to do very well. And then above 36, I show them they're in the red zone. They need another kind of doctor besides me, a doctor who will aggressively get their weight down. This article has made me more strict than that. It says 30 is that cutoff, not 32. So I am going to change the way I do things. The other way I'm going to make a change is one of the other factors, which was length of surgery. It turns out longer than about 6 hours, the complication rate begins to ascend more rapidly. So I tell my patients, if you want me to do more than one thing at a time, I'm going to add up my estimate of how long it'll take. If it adds up close to or longer than 6 hours, I will recommend that we break this experience up into pieces and have this surgery at one time and wait a few months, come back and do that one. And I know you don't want to have more than one surgery, but I also know you don't want to have major complications. And sometimes the patient and I have bitten off too much and wish we hadn't. I admit that. This article, I'm hoping, will change that as well. Interestingly, I had already started limiting my procedures to about 6 hours because I'm older. And sometimes I'll look a patient in the eye and say, which one of these procedures that we're going to do you want me to do a less than good job of? And the patients go, what do you mean? I'll go, well, because 4 or 5 hours into it, I'm getting tired and I'm getting hungry and thirsty and I'm losing my creativity. I just worry that I might not do as well. I'm not sure, but I want your opinion. And at that point, the patients often go, well, wait a minute, let's do it at a different time. And finally, combination procedures, which probably gets at that length of surgery. But if you exclude length of surgery as a factor, they still found that combined procedures, especially combining with liposuction, greatly increased the complication rate. It wasn't explained why that would be in here, and I've seen some other papers that came to the same conclusion, but so far there's no explanation of why certain combinations, mathematically you could say, well, you add the complication rate with several things, you're going to get mathematically the summation of that complication rate, but it seems to be a little bit even more than that. But those three factors, combined procedures, high BMI, and length of case, I'm going to make a little bit of change here. Like a lot of other practices, we've decided to pay closer attention to our patients' weight, overall health, and percent body fat. There's some changes we're going to make based on this really good article I wanted to let you know about. Thanks.